All right, so today's topic, advances in the treatment of speech and swallowing disorders, very patient-friendly, and let's get started. While I'm talking, if there's something, a burning question that you are welcome to pose that in the chat box, or if you prefer, you can unmute yourself if it's something I can address at this moment. Otherwise, we're gonna open up the floor to all different types of questions and discussion at the end of today's lecture. So a little bit about myself, as Chris mentioned, I'm an internationally recognized medical speech language pathologist, keyword medical SLP. I'm a very proud multiple sclerosis certified specialist, a researcher, author, and an associate professor at Yeshiva University's graduate program in speech language pathology, where I also serve as the department chair or program director, leading 6 faculty members and 90 students on their journey to becoming medical speech pathologists. I have lots of training in the evaluation and treatment specifically of neurological conditions, and I'm very passionate about my international lectures. You name a country, I've probably had the opportunity to share my knowledge there, anything from the topics of MS to motor speech disorders, cognition, swallowing, and neurodegenerative disorders. I'm a very proud member of the Clinical Advisory Council for the National MS Society, and for many years I've also been able to sit on the advisory board for the MSF, our Multiple Sclerosis Foundation, and in 2012 I was granted an MS Rehabilitation Fellowship. In 2012 I was also asked to serve on their Distinguished Faculty Board, and this past year I have been the recipient of their Healthcare Professional Champion Award from the National MS Society. So, and my private practice is also a recognized MS Center for a Partner in MS Care. So all things MS, I live it, I breathe it. My Ph.D. was in MS Care, and I'm excited to share really functional and relevant information with you today. So what are some of the facts? Let's lay down the foundation. Impairments with communication and swallowing have long been identified for persons with MS. In fact, about 44% of individuals with MS experience impairments of voice and speech very early on in their disease course that often go unrecognized by healthcare professionals. And the same can be applied to swallowing disorders, or a term that we call dysphagia, with about 33% of our MS friends experiencing challenges with voice and swallowing early in their disease course. About 45 to 65%, that's a pretty wide range, of individuals living with MS experience subtleties and difficulties with memory, attention, word finding, having that tip of the tongue syndrome, and problem solving. But it's really important to know that there's very little relationship between the severity of physical symptoms that you or a loved one may experience and their cognitive or difficulties in these executive skills we just mentioned. So what does that mean? Somebody who may have severe challenges in physical skills may be sharp as a whip, but other friends who may have increased mobility may... Someone was muted, thank you. So there's a mismatch. Physical disability doesn't necessarily mean cognitive disability and vice versa. So the bottom line here is we are to never judge a book by its cover, and each person living their life with MS every great day of their year should note that they are individualized in their presentation. So referral for treatment is essential. This is what this talk is about, you advocating for you and your loved ones. Despite these really high numbers of occurrence or the likelihood that you may experience a change in your speech, your swallowing, your voice, or your cognition, only 2% of patients with MS are appropriately being referred to individuals like me and my colleagues who are healthcare professionals, licensed and certified specifically to help improve quality of life and the issues that we're talking about. And only 1% of patients appropriately receive cognitive intervention. And cognition is so essential. Participation in community and family functions, maintaining longer in the workplace. So it's very, very important that you become your best advocate. And in particular, it's important to note that medical speech pathologists have a very important role in MS rehabilitation, and for a very long time. But I feel often that we might not be recognized for our contribution into the larger continuum of care for MS. And if you or your loved one is one of the individuals who now have a oral formulation, which is a fancy word for a pill, that you are using a part of your disease-modifying therapy, it is so essential that you are in communication with the medical speech pathologist, because we're going to talk a little bit more about the importance of swallowing and oral formulation medicines, right? I think we could all agree that back in the day, most MS disease-modifying therapies were largely infusion-based or injectables, but now we're moving to oral formulations. What a blessing. But that's not a blessing. You have difficulty swallowing, and that very important medicine could accidentally go down the wrong pipe. So just some food for thought. So let's talk a little bit about speech and swallowing. There are many different types of challenges that persons with MS may experience, but today we're going to focus on two really important ones. The first one, the term is dysarthria, and the second is dysphagia. So let's talk about these two terms. Dysarthria. Dysarthria, by definition, is a neurological motor speech disorder characterized by slow, weak, or uncoordinated movements of the speech musculature. Well, what's the speech musculature? There's many different parts of speech musculature. Lungs, vocal cords, the velum, which is another word for soft palate, your tongue, your lips, your nose, and even your jaw. So when we have challenges in the ability to execute and coordinate muscle movements responsible for speech, we can develop a condition called dysarthria, which is a neurological change into the way in which we use our articulators. Very important to note that often respiration, our breathing capacity, can become disordered and under-innervated or weakened, causing sometimes speech to be soft in vocal volume. Our articulation, or the clarity of the sounds that we make, can become a little slurry, and our voice can sound pressed or harsh or tense, even if we're not feeling that way. So dysarthria overall can cause a change in speech intelligibility, clarity, and the ability to effectively communicate with your loved ones and people within your community. And often dysarthria can be a cause of social isolation and depression, and not just for persons living with MS. That's for any individual who can experience this condition, right? Those can be persons with ALS, the persons who've had stroke, Parkinson's disease, progressive supranuclear palsy, and many, many others. So dysarthria can occur in two contexts. Episodic, meaning that the dysarthria can last for just a few minutes or hours, or it can reoccur. These moments of really challenges in communicating can occur a few times during the day. Typically, we see episodic dysarthria associated when you are feeling at your highest levels of fatigue, right? And we cannot not talk about the importance of MS fatigue or MS lassitude, right? Because fatigue is one of the number one symptoms associated with persons living with MS. And successful management of fatigue should be on everyone's number one priority, right? Because that leads to increased quality of life. So sometimes dysarthria can kind of come and go, associated to when you're feeling at your very most tired. And then other individuals in different parts of their disease course may experience consistent dysarthria, which means the symptoms that they're experiencing, the pressed voice, the challenges in breathing, the under-articulation or the slurry, sloppy speech will persist all day, every day, and perhaps only worsen under those periods of high fatigue. So what are the causes of dysarthria? Well, the causes of dysarthria, typically for persons with MS, are due to bilateral upper motor neuron dysfunction and lesions found within the cerebellum. Okay, that's the medical underpinning. But from a really easy to digest perspective, we're going to see a lot of changes in respiration, which is the driving force for successful communication and speech clarity, usually due to deconditioning. And deconditioning can be the result of a more sedentary lifestyle, right? Not moving your body as much as perhaps you did earlier, and sitting down more, and less likely to take the stairs, and all of these physical changes that encourage you to sit more or do less physically. That can lead to deconditioning. Underuse of that respiratory system, you used to talk a lot, perhaps you were in sales, and now you're talking less. So you're not using the respiratory system in the same way that perhaps you did earlier. Disuse atrophy, meaning as we don't use muscles, they begin to lose certain muscle strength and fiber functions. This can occur in the respiratory muscle. And of course, poor positioning, the presence or coexistence of scoliosis or kyphosis, which is that kind of hunched over, rolled over position, right? This is somebody who's sitting kyphotic. Very hard to breathe and take a deep breath and restore all the air when all of your body weight is sitting on your diaphragm. So sitting up, being aware of your body posture can immediately increase the quality of your communication for certain individuals. So in short, dysarthria makes speech sound perhaps sloppy, imprecise, uncoordinated, or really effortful, okay? And the vocal quality itself can be harsh or maybe hoarse, breathy, and or nasal. So I have some examples to make this easy to understand. So dysarthria, which is vocal weakness paired with reduced respiratory support, can cause you to speak with a reduced vocal volume. Has anyone here, just raise your hand up in the video camera, experienced a softer vocal volume over their disease course? Does anyone feel? I see quite a few hands up. Okay. All right, you are not alone, but there's so much we can do to reverse this. So this is all about positivity. Yeah, thanks, Robert. Thanks, Brenda, and many others. Wonderful. So volume has a lot to do with lung capacity and endurance and increasing your ability to use all of that air for effective communication. Okay, so running out of air when communicating is frequently reported by persons with MS. And in fact, we know that on average, individuals with MS have about 8 decibels less volume than the other average adult. So 8 decibels, it's not huge, but it's not insignificant. Any change in vocal volume is worth addressing because it improves your communication and quality of life. So I have some interesting facts about that 8 dB and how we can fix it. So let's talk about therapy, right? Let's be positive. How do we get back on track? So one of the best ways you can improve this entire system from belly button to the nose and everything in between, critical for effective communication, is using a technique called LSVT loud, the Lee Silverman voice treatment. Now, yes, initially, this treatment was developed for persons living with Parkinson's disease, but over the course of the last 20 plus years, we have found that LSVT is incredibly effective in treating many, many different conditions, including multiple sclerosis, changes in voice associated with Parkinson's disease, cerebral palsy, children with Down syndrome, stroke, so on and so forth. So it is the #1 exercise to help improve vital lung capacity, the powerhouse to your communication. Breath support, not only just for speech, but vegetative purposes. We're always breathing, even if we're not communicating and if we're sitting in our homes. It focuses on strengthening those intercostal muscles, the muscles that run between our ribs and the diaphragm, which is that driving force. It improves loudness and intelligibility, and it even improves swallowing because some of the exercises that we do, a part of LSVT, imitates and emulates a part of the swallowing process. So you really get a lot of bang for your buck when you participate in this type of therapy. And the great news is that LSVT therapy is a wonderful therapy that is, of course, covered by Medicare insurance providers. It's a form of speech-language pathology, and it has been successfully researched to be delivered in a telehealth modality. Because I don't know about you, but here in New York, we are 100% telehealth because of COVID. So if you find yourself in a similar circumstance, there is great treatment from the comforts of your home. So I want everyone to take a try and do this with me. This is one of the first ways that you can kind of identify whether or not you're having changes to your respiration, your breathing, and your phonation, the activation of your vocal cords. So I'm going to have you do what I do. We're going to take a deep breath in, sitting up nice. Take a deep breath in. Open your mouth up wide, and I want you to say, ah, until you have no more air left, okay? All right? So I'm going to do it with you, and I'm going to time myself, and we're going to get some data here, okay? Let's go ahead. Okay. Let's go. Stopwatch ready. Take a deep breath with me. I can see all of you right now. Deep breath in. And say on until there's no more air left. Keep going. If you can keep going, keep going, keep going. I see some friends still going. Good job. Good. You can stop if you haven't already. So what does this tell us? Why do I keep my timer on? Because we know that there's some data to suggest that this exercise or this activity can help determine if you need to work on your respiration, a part of your therapeutic plan. So men, typically, it is believed that you should minimally be able to sustain a nice strong between 20 and 40 seconds. Ladies, 15 and 35, and children, 10 and 18. So if you feel, you can go ahead and try this after this webinar and see where do you fall within your values. If you did not easily fall within those normative values, this could be one area for you to consider for self-improvement. Remember, your lungs and the ability to coordinate with your voice box is essential for your communication and speech clarity. And this is a huge part of the LSVT program. When you focus on the coordination between these two very important systems, subsystems of phonation, articulation, and respiration, amazing things can happen in terms of speech clarity. So I actually did some research early in my career using this technique specifically for persons living with MS, okay? So I looked at 5 individuals, all of whom had relapsing remitting multiple sclerosis, 3 women and 2 men, all who had a disease range in terms of how long they've had MS between 13 and 18 years. So it wasn't newly diagnosed individuals. All 5 of the participants received the standard care for LSVT, which is 1 hour of therapy 4 times a week for 16 total sessions. So this is an intensive therapy that is going to completely rev up these systems that I've mentioned, okay? We did some statistical analysis looking at where the patients were and where they were after the completion of their therapy with me, okay? We looked at that big valve, the phonation of the sustained ah. We looked at a monologue, having a communication dialogue for 2 minutes, and their ability to indicate they needed help. So using help, nice and loud and clear. What did we find? Statistically, from a values perspective, we saw that our patients had a statistically significant improvement in all of the post-treatment observations. Their ability to sustain conversation with the vocal loudness, their sustained ah, and their ability to call in for help. So all 3 of the things that we looked at were statistically significant in terms of those research values. And interestingly enough, look everybody, the average person living with MS who participated in the study, who received a standard course of LSVT loud therapy, increased their vocal volume by 8 decibels. Why is that an important fact? Who remembers? We mentioned in an earlier slide that the average person living with MS has about an 8 decibel loss of volume. So this program, for many people, gave them back, on average, those 8 decibels that were often associated with the disease course. Well, that's a huge, huge, huge quality of life and communication issue to be excited about. We also saw that there were big changes in forced vital lung capacity. That's your lung's ability to take in air and use it effectively, right? About an average of 680 cc. So all these numbers, the takeaway point is that when using LSVT loud, for persons living with MS with a qualified medical speech pathologist who trained in this technique, you will likely experience significant increases of quality of life and communication. Here's some additional data. Look, you could see patient 1 was starting with less than 65 decibels for her loudness and ended with over 70. Patient 2, 72 versus 80 decibels. That's huge, right? Look at patient 4. Initially, this individual had a vocal volume of about 73 and ended with 85, much greater than the 8 decibels. So the average was about 8, but you can see that there was lots of improvement, and every single patient had an improvement in their average ability to sustain that ah. Let's listen to them. How about that? Let's listen to see how they sound. Just give me one moment to ensure my sound is on. Okay, one moment. I'm going to stop sharing just for a second to ensure that the sound quality is excellent. Okay. So let's listen. Okay, did everyone hear that? That was a little gravelly. You can say it was harsh and a little hoarse. Now let's listen to that same individual after their 16 sessions with me. Longer, but smoother, more in control, less gravelly, and less pressed. Would you agree that those are some of the words you could use to describe those two voices? Absolutely. Let's listen to another. Here's participant 5. Okay, let's listen to participant 5 after his LSVT therapy. And I love the giggle at the end because he has so much pride in his new and improved voice, right? So here are some examples. All right, so a part of the research study was upon completion of the therapy, I asked friends and families to go back and listen to those initial monologues and to judge their loved ones. And initially, some of the loved ones said that their family member's speech was not clear, or it was clear some of the time. But at the end of the therapy, when we went back and listened to the new monologues, the loved ones reported that their friends and family said that their speech was clear the entire time. So perceptually, the people who matter the most, the husbands, the wives, the spouses, the bosses, the grandchildren, all thought that their loved one's speech clarity had improved. And that's so important. Okay, let's listen to them speaking. Here's participant 5 again.
Teflon is a permanent type of injection implant material. It has some long-term risk of a foreign body reaction which can cause the voice to deteriorate some years later. The body.
So once again, the voice is soft, He is kind of running out of air, but he's pushing through. You can kind of hear that breathiness, right? But let's listen to him after therapy. Oops.
Ladies and gentlemen, may I have your attention. Good evening. My name is Nate from Primetime Entertainers. On behalf of Tony and Tina, I'd like to welcome you to the beautiful Motel 6.
So this gentleman who had multiple sclerosis worked as a DJ and an MC for doing parties, right? And he focused on actually doing parties for people of the same age as himself. So someone who's having a 50th anniversary party, somebody who's having a retirement party, people of his same age demographic. And that was his introduction, his monologue, and it sounded beautiful after our therapy. So LSVT is one way. That's a commitment to a 16-session program, usually in the course of 1 month. But there's other things speech pathologists can do alongside with you. There's something called the breather. And the breather is a form of resistant therapy or breathing therapy, expiratory muscle strength training that helps us improve the breathing system. It helps us improve respiration for phonation, articulation and swallowing, the skeletal muscles in our neck and our pharynx and in our larynx. And this can be very helpful when we strengthen these muscles to reduce the likelihood of developing a condition called aspiration, which we'll talk about in a moment. And aspiration simply means that food, saliva, liquid is sitting on top of your vocal cords, or if it's slid below your vocal cords and it's entered your airway. So penetration is when there's food or liquid on top of your airway, and that itself can slip into your airway, causing you to have difficulties with breathing or developing a pneumonia. Or aspiration, when that food or liquid or secretion goes below the level of vocal cord. So the more we can use resistant breathing, the less likelihood that these materials will sit on top of the airway or go below the airway, which can be very, very dangerous for all persons, right? The breather is relatively inexpensive. You can get it on Amazon. You can buy it on the web. It costs about $28, and it has an entire program that you can follow that helps you improve your ability to inhale, take air in effectively, and exhale using these different dials of various degrees of difficulty. So I encourage you to look into the breather, a part of your regimen. Many of my patients all over the world use the breather and other similar devices. There are many others of a similar type, a part of their daily exercise routine, okay? Another example is an incentive spirometer. An incentive spirometer may look like something you have seen, whether you've been in the hospital or if you had a baby, they give you one of these. But the most important thing is that sometimes these devices include dials that increase resistance, and sometimes they're just simply devices in which you blow and a ball goes up and down. In order for it to be effective for what we want it to do, it has to be the type that has a pressure valve, making it more challenging or less challenging by changing that valve. So that's the type of incentive spirometer you would want to consider, right? So it helps us, once again, look at improving respiration for speech, but also vegetative, your participation in your community. It aids in that increased respiration. And our goal would be to increase the pressure over time while still being able to maintaining that endurance, okay? All of these things should be supervised with a medical speech language pathologist to ensure proper, safe, and effective use, okay? Okay, let's talk dysphagia. Dysphagia is a fancy word for challenges in swallowing. So dysphagia simply means difficulty swallowing. It can occur about 1,000 times a day. Wow, that's a lot of times. Wouldn't you all agree? About 1,000 times per day, you swallow, but you're often not thinking about it. It's really not a conscious act. Well, that can lead to some difficulties, right? Because we know about 60% of individuals with multiple sclerosis have challenges and difficulty with swallowing within the 15 years of their initial diagnosis. And as you can see here, right, as food enters the mouth through the lips, the bowl of food will be masticated or chewed and made into a bolus or a ball within the oral cavity. And then it's going to be propelled backwards into the pharynx. Your epiglottis is going to close. Your larynx is going to come up and forward. And the esophagus, the food tube, is going to expand, allowing for that bolus to pass. Now, if this entire system is not perfectly coordinated, and there's so many small places where the system can go awry, food or liquid, as we indicated, saliva or even secretions, can accidentally sit on top of the larynx, the voice box, and slip below the larynx, which is our trachea, which is our airway. And that is extremely dangerous for anyone, right? Me, you, anyone. We never want an unknown or an unwanted substance in our airway, okay? And we call these events aspiration events, okay? Dysphagia, the term clinically comes from Greek, meaning disordered or atypical swallowing. Refers to any abnormality and challenges in moving food or liquid, or as I said, also saliva and secretions from the mouth to the stomach. It is not a disease, but it's a medical diagnosis associated with many, many conditions, and it can occur in children and adults. And MS is one of these conditions. It is essential that if you have any challenges in swallowing, that you are in immediate and close contact with the medical speech language pathologist and your MS neurologist, nurse practitioner, or PA knows. Because this is one of the largest areas for under-referral or underutilization of our services. Okay? And many of the scales that your doctor may have administered when they see you, something called the EDSS or some of these MS scales that help us gauge where we can best support you in your clinical rehabilitation. Many of these scales often are not sensitive to challenges in swallowing. And not to be grave, but challenges in swallowing is very, very complicated because if food or liquid or saliva or secretions go down the wrong pipe, the consequences could result in death. That's not because of MS. That's because anything that belongs or happens to go into the wrong pipe could lead to respiratory infection, could lead to cardiac arrest, and could lead to somebody ultimately expiring. So this is why swallowing should be very, very carefully monitored for each and every one of us, okay? So it's true, it's not typically one of the first things that we observe with MS, but the prevalence increases as the disease increases. As much as 65% seen in persons with MS as their disease progresses, right? Looking at large research studies, meta-analyses that go back, right? And look at the research, we can see that the estimate is about 36% for 1/3 of individuals living with multiple sclerosis, increasing to about 65% with persons with greater disease severity, okay? So this is a relatively common but underlooked at area that's important for your self-care and advocacy, right? And we also know a little bit, if you know a little bit about where your lesion loads may be, we see that sometimes persons with MS who have a greater presence of lesions in the brain stem can have a higher association with swallowing. And that's because the brain stem plays a huge role in the safe execution for swallowing. So these are all topic conversation starters for you to have with your MS practitioner. So what causes swallowing dysfunction? Well, dysphagia or difficulty swallowing could be due to decreased neurological drive, that energy from the brain to the swallowing musculatures, insufficient sensory feedback or awareness as to where the food and liquid may be within our system, changes in our jaw mobility and restriction, changes in airflow, anatomical changes to the mouth and the swallowing musculatures, muscle atrophy or changes or less muscle tone due to disuse, often paired with a sedentary lifestyle, and poor positioning, once again, kyphosis, scoliosis. It's so challenging to swallow if all of your body weight is sitting on top of your diaphragm and not over your hip bones. But as soon as you allow yourself a very natural position, swallowing can improve for many individuals because everything is stacked up in alignment, okay? It's a small thing that can lead to big changes in success. So what are some things you should be aware of or you should be mindful of for your loved ones? Coughing or clearing your throat, an abnormal volitional cough, not being able to cough on command. Ready, everybody? 1, 2, 3, cough. If you have difficulty making that fast volitional cough, that could mean that there's some challenges in your swallowing. Decreased vocal quality. Your voice sounds wet, especially after eating and drinking. It's kind of like you're underwater. Your voice may be harsh or weak. Recurrent chest infection, the need to swallow many times or to maneuver your throat and your neck in ways to get the food out of your pharynx. Very long meal times, taking 30, 40, 50 minutes to complete a meal. The sensation of food stuck in the back of your throat, changing your diet, you have eliminated entire food groups. You now eat things that are soft and pureed. You no longer eat certain types of meat because you find them challenging, right? This is often a sign that you're experiencing changes in your swallowing that requires medical attention. Difficulty starting that swallow, or food, liquid, saliva coming out of your lips or throughout your nose rather than being able to effectively move to the back of your throat. Okay, so these are some just a few of many, many different types of symptoms associated with swallowing dysfunction. Here's a little bit of research. When we polled 360, not me personally, let me take that back. When researchers polled 360 individuals with multiple sclerosis with known complaints of dysphagia, okay, 64% of patients had an undiagnosed dysphagia, okay? While only 36% had a proper diagnosis. Patients, many of them, didn't believe it could be treated. 61% thought there was no hope for them. There was nothing that could be done to help them. That's so discouraging to me. This is my dream. This is my life. This is every day of my life. I have committed to helping persons with MS and other similar neurological conditions have a high quality of life and improve their swallowing. So there's a lot that can be done. And only about 39% thought that it could be treated. So there's a lot of misinformation regarding getting the right diagnosis and whether or not you know what can be done to help you. So this once again goes back to the positivity of today's Lunch and Learn, you being your own best advocate. So since the development of oral formulations, AKA pills, now for disease-modifying therapies, it is essential that your swallowing be monitored. Why? We know that our disease-modifying therapy is essential for keeping our disease at bay. MS is not the type of disorder when we're having a bad day, we take a pill. It's not a headache. We take our medicine religiously, exactly as prescribed, to keep our body optimized, right? But if you're taking a pill and you have challenges in swallowing, and that pill or a portion of that pill is going into your airway and not into your belly where it needs to be broken down and absorbed to keep you in tip-top shape, guess what? Not only is that incredibly dangerous from an upper respiratory function, your disease-modifying therapy will not be optimally utilized to protect you and your brain, because the entire pill is not going into your food tube, into your tummy. It's going someplace it's not supposed to go. So if you are on a disease-modifying therapy, you must advocate for yourself. This has been my soapbox for many years now, since I'm so happy that there's pills for MS. I love it because it has improved compliance with disease-modifying therapy all over the world. But there has to be additional consideration for candidacy, making sure you are a safe candidate for disease-modifying therapies that are in oral formulations. And you need to ensure that. And once again, you need to advocate to your MS team to ensure your safety, right? So why? Why? Because the consequences to dysphagia are high. This is not specific to MS. This is to any human being who experiences these challenges in swallowing. They are high risk consequences. You can develop aspiration, respiratory distress, pneumonia, ultimately death. You can experience choking, a compromised airway, the need for a tracheotomy, malnutrition, dehydration, weight loss, chronic respiratory illness, or ultimately requiring a feeding tube, whether it's a PEG tube, an NG tube, an OG tube, a G tube, a J tube, all the tubes. So dysphagia, for anyone who experiences subtleties in swallowing, should be medically managed, because these are very, very serious consequences for all human beings. So there are lots of different treatment options and different ways that we can approach improving swallowing efficiency and safety. But I'm going to focus on just a few that I think are innovative and less known and are wonderful ways for you to consider into the incorporation of your dysphagia treatment plan. The first is biofeedback, which can include surface electromyography and ultrasound. I'm going to tell you what these are in greater detail in a moment and even give you examples. The next is neuromuscular electrical stimulation, which is the science of using small electrodes on muscles and nerves of high interest to help activate and engage them during the process of swallowing. And neuromuscular taping. Neuromuscular taping is the term often associated with a kinesio tape. Kinesio is a brand, it's not a science, but you may have seen persons in the Olympics and athletes wearing these colorful tapes, reds and greens and blacks on their body. These tapes have elastic qualities that can help change muscles and nerves and fascia, and they can be used by speech pathologists to facilitate your swallowing. So let's talk a little bit about some of these. So the first thing, my personal passion, I've lectured all over the world, quite literally all over the world, on how to implement neuromuscular electrical stimulation, which are small, carefully calibrated electrical currents to this submandibular triangle, to this area right here. I did not say the neck, I said underneath the chin, where there are some important muscles of interest that help facilitate normal swallowing. When we apply these carefully calibrated electrical currents underneath the chin, we have seen that it elicits this process of neuroplasticity, helping the brain come up with pathways to optimally execute certain types of behaviors. And it can also strengthen this process of hyolaryngeal excursion. So if you remember when I showed you the picture of the person at the definition of dysphagia, I said that when we swallow, very casually put, our voice box comes up and tilts forward when we swallow. Imagine like a diagonal line between the voice box and the tip of your chin, right? It's coming up and forward. That is a very, very important part of swallowing. It's very important. You don't have to, I could give you days and days and days of lectures and information about that process. But ultimately, that process is called a hyolaryngeal excursion. And we know that when we begin to pair these carefully calibrated electrodes with the process of swallowing hard, we see that this hyolaryngeal excursion can improve. And that can improve swallowing safety. Okay? So when we use NMES carefully and under the trained individual, not every speech pathologist is trained in this technique. You need to find someone who is, and I can certainly help you if that's an interest of yours. We know that this type of therapy paired with dysphagia therapy can help improve muscle contractions and improve the brain's representation for swallowing. And that is very, very, very powerful. So here's an example of me working with one of my patients. I was cleaning her skin underneath the chin, feeling for the muscles of interest. In particular, these two muscles are called the anterior belly of the digastrix. Don't worry about the name, but they're found underneath your chin. I'm applying electrodes, right? They're very small, they're very gentle. I'm finding a therapeutic dosage of very, very small milliamps that helps stimulate those muscles and nerves. And every time that device comes on, she feels the muscles come to a contraction, I'm having her swallow too. So we're coordinating the patient's effort with the electrical current. And I have an example. Here you can see the electrodes underneath the chin on these important muscles here. And no electrodes are ever applied onto the neck. We call this the anterior neck. That's not where we want to make a difference. A lot of swallowing drive takes place underneath the chin. And I think people don't realize that. I think they think it happens from the neck, when in fact it happens in this region called the submental region and the suprahyoid muscles, which are found there. So here's how the therapy works. Here's a little video. There's no sound, just a picture, and I'll describe it to you. Here's my patient. I say, hi, I'm going to place two little electrodes underneath your chin in very carefully decided area. The electrical current goes on, the brain activates, and the patient, if you notice, swallows the food while the electrical current is underneath the chin. So we're pairing the activation from the device with the patient's effort. And we're creating a coordinated, improved swallow over time. Okay? That is neuromuscular electrical stimulation. Okay? Here's an actual example of somebody's voice box going up, 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 and then down while wearing this device. So the patient in this video is not going to be swallowing. I didn't ask him to swallow. I just wanted to show what happens when those electrodes are activated on those suprahyoid muscles, and it pulls the structures up and forward because of the electrical activation. Okay, here you go. Up, 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 and the larynx goes down. And he says, oh my goodness, I can't believe that just happened. Watch again. Look, and you can see. Up, up, up. And when the device turns off, he says, you can see his little voice box going up and down. Oh my goodness, I've never experienced that before. So you can see that's kind of how the therapy works. So this could be a great option for you depending on your dysphagia and the availability of trained professionals in your region. And this is also a type of therapy that can be done via telehealth for qualified individuals. So on average, we have seen a change in that laryngeal elevation. In this research study looking at electrical stimulation, treating pharyngeal dysphagia, they saw that they went from pre-treatment about 0.6 centimeters, and after therapy, they were experiencing about 2 centimeters of hyolaryngeal excursion, which I said, and this process is so important. It's one of the most important driving factors of safe and effective swallowing. It's not the only, but it's a huge, huge factor. So here you can see that when we have this therapy, done correctly to the right types of qualified candidates with the right type of training, you can significantly improve high-laryngeal excursion, which is essential for swallowing safety and efficiency. So the benefits of that contraction, when that device went on and you saw the patient's muscles elevate and change, it helps strengthen deprived muscles. It helps us maintain and regain a range of motion of the whole system. It helps us regain that volitional motor control over the system. It helps improve microcirculation, metabolic exchange, lymphatic and venous drainage, and pulmonary oxygen uptake. So there's a lot more to the science of using electrotherapy than you may have realized. So what makes NMES so innovative? Because it elicits brain plasticity and can help patients enable and recover certain swallowing functions that otherwise would not be able to be targeted through quote unquote traditional therapeutic exercise alone. Every patient needs a personalized care plan. And sometimes NMES is often the missing link to getting you to where you need to go, okay? And if you do have a loved one whose cognition has been challenged due to MS, Parkinson's, ALS, stroke, Down syndrome, cerebral palsy, what's nice is that we can continue to do this therapy even if they're having challenges in cognition, that we're able to utilize this therapy for those persons who might not be able to willingly participate as much as they could. So we can still work within the confines of cognitive challenges. So I did a research study looking at this as well. And I looked at persons with relapsing remitting multiple sclerosis, eight individuals, okay? And the disease history was about 17.3 years. That's the average time the person living with MS participated in my research study. I did the therapy exactly as you saw in those videos. And in my study, we saw that the speed of swallowing, the oral pharyngeal transit time, on average was about 18 seconds for the group, right, of those 8 individuals. And on average, it was reduced to about 10 seconds. Now, these are both elevated numbers. I would still want somebody to have an oral pharyngeal transit time less than 18 and less than 10. But going from 18 to 10 across the group shows a significant movement in the right direction towards things that are quote unquote more normal. The movement of the Adam's apple, that hyolaryngeal excursion, improved in 62% of research subjects. In 88% of my participants reported coughing and or choking 2 times or less during a meal, when initially every single person said 100% of the time, I cough or choke at least 4 times per meal. So they were seeing improvements, their own perceived improvements in their ability to safely eat. Now, this is not the holy grail of research, but it gives us lots of areas to continue investigation on using these types of treatments to improve swallowing safety. The goal is never perfection. The goal is always progress, okay? And this study illustrates progress, okay? And all of my participants reported less fear when eating upon conclusion of their therapy with me. And not a single one of my participants developed an aspiration pneumonia 6 months after the therapy was completed, even though they were quote unquote high risk for aspiration, a part of the enrollment process. So we were able to avoid these 8 individuals from developing an aspiration pneumonia despite their quote unquote high risk. So I was very, very happy. Another thing you can use, something called the Bionic Safe Straw. This is something that's great because it's kind of incognito. It's a special device that you add to any standard straw that helps limit how much liquid you take at any point in time. So when we slow down and control the amount of liquid, for some people, this could reduce the likelihood of aspiration and or penetration. It's not a one size fits all. This is something that you could develop with your speech pathologist and your healthcare professional to develop candidacy. Here's what it looks like. It's a regular drinking straw attached to this device. And if you see here, there's a little weight here. And as the patient takes a sip, it comes up and only this much liquid is allowed into the tube. So you can't take more than what that tube allows for. Okay? So once again, not a one size fits all, but for many, controlling the amount of liquid per sip can be effective. All right? And there's two versions. There's one for thin liquids, which are everyday liquids, and some people may have liquids that are thicker. They may be prescribed those types of liquids. So there's one for thin and there's one for thick. So even if you may be on a thicker liquid, there is a straw device that will also be effective for those thicker liquids. So this is a very easy, once again, inexpensive, possible way to help you manage. Once again, not one size fits all. Okay, our last two things we're talking about, biofeedback. Biofeedback is so cool. Imagine you can sit in front of an iPad or an iPhone, hooked up to a little device, completely painless, two stickers underneath your chin, right? Electrodes, not delivering a current, but just collecting the electrical energy that your muscles fire out when you swallow. Completely painless. Absolutely, you feel nothing. It's just capturing that data. And it made it into a picture. And you could use that to say, oh, I should swallow harder. Oh, I should swallow differently. Oh, look, I swallowed twice, but I didn't even feel that. Biofeedback is using that picture and that data, which represents your physical effort to help you better understand your swallow. So surface electromyography is a measurement of your muscles recruiting or activating, measured in microvolts, where ultrasound is a different form of biofeedback, where we use sound waves to create a picture of what's going on. So both of these can be used for swallowing rehabilitation. So here are two examples of devices that can be used for surface electromyography. That's capturing the data being produced underneath the chin and turning it into a physical picture, okay? Here's an example of some of my patient's swallows. Look, this patient had no idea that he or she was swallowing twice, which for her, actually this is a her if I remember correctly, was making her very fatigued about 10 minutes into her meal because she was double swallowing every time. So maybe for some individuals, that's not an issue. Once again, this is not one size fits all therapy, but for this individual, it was fatiguing her. We would never have had that ability to give her that immediate feedback at that moment if we weren't using surface electromyography. So I could say to this patient, okay, Ruth, look, here we had two swallows right in the beginning. What can you do to give me one good swallow, one coordinated, effortful swallow, right? Because one strong swallow may be more effective than two little swallows. So using these pictures to guide the swallowing process. Okay, say the patient's really, really having a tired day. You would say teeny tiny little mountains as a representation of their effort. But over time, as their swallowing hopefully increases, we would want to see what? Bigger mountains, if you will, being drawn as an effort of their physical representation of their effort. So this is a really great way. It's objective data. It's not subjective. That shows us exactly what's happening all the time, right? Say you put the food in somebody's mouth and there was a blue flat line for 10 seconds. That would tell me that the patient is not in fact swallowing and they're just keeping it in their mouth. Well, that would tell me, oh my goodness, that's a big delay in swallow. Something that I might not be able to do if I wasn't having them wear this simple little device. It tells me information that I cannot see because I don't have X-ray vision, right? And swallowing takes place in a closed system. Yes? Here's an example of ultrasound. We place a transducer in the same region, the suprahyoid region, and it makes a picture. You're going, oh, Dr. B, what is this? Well, this here represents the tongue, okay? And here is the bottom of the mouth and some of these muscles of interest. So when somebody swallows, and here is their mandible, this dark area here is bone, and this dark area here is bone. That's the hyoid. It's the little bone between here and here, and that bone is very important. The movement of that bone up and forward is a part of that hyolaryngeal excursion, the hyoid of hyolaryngeal excursion. So here's what happens. Here is a picture of my patient swallowing with ultrasound underneath the chin, and here's the cue. Okay, Mr. Smith, swallow hard. And what's the goal? To get that black box here that appears, that's the hyoid bone, into that box, serving as a visual target. Get in there, boom. That tells me that's a strong, effortful swallow. And again, 1, 2, 3, swallow. Okay, once again, you would never know about the movement if you didn't have a way to visualize it. Now, these are very sophisticated, complicated techniques on the clinical side. And if you have a chance with greater time with a speech pathologist, they can show you how to use these technologies for you and you personally. But this is just the very, very, very tip of the iceberg. But it's nice to see that there is a way for you to know how much effort you need to put in to effectively have a good swallow. And last but not least, here is the application of neuromuscular taping, right? Here we're going to take these muscles, once again, that I keep talking about, the anterior belly of the digastrics, which are very, very important in driving that hyoid laryngeal excursion, that up and forward movement. And we're going to apply tape in a very specific way that's going to help give directional sensory stimulation in that upward and forward movement. Help remind these muscles and nerves that the direction of success is up and forward, making that diagonal line from the hyoid to the chin. So you can wear this tape 2 and 3 days between your therapy to act as that sensory stimulation to help those muscles and nerves remember where the target is. What's the target tissue? What's the target movement? Okay? Super inexpensive, costs pennies. And once again, you have to make sure that you have a qualified speech language pathologist who's trained in this technique to ensure that it is done safely, but it can be very effective for many individuals. So we only have a few minutes left. What's some food for thought? 1, speech, language, and swallowing of function can occur more often than not for persons with MS, but there is so much hope. There are so many things that can be done. Like I said, this presentation is just a very, very small overview of some of the cool things that I would like to show you, but there's many other things that we can do as well. And the expertise and training of medical speech language pathologists are underutilized in MS care. Fact. So the use of telehealth is beneficial. The use of in-person therapy when it's safe and appropriate can be helpful. This is not a commitment to therapy for years and years and years. Sometimes having a good evaluation, having a tune-up, a check-in can serve to be a tremendous benefit for you to understand where you are with these 2 sets of skills, speech and swallowing, okay? So consider this. Consider this a part of your yearly checkup for your body. There are many inexpensive, effective ways to help promote speech and swallowing dysfunction. Some of these interventions require consultation with medical speech pathologists who are trained and knowledgeable and maybe even deemed competent in certain techniques, like electrical stimulation, ultrasound, EMG. You don't want to just take anybody off the street and ask them to do these techniques. You want to talk to them and say, do you have experience with this? Do you know how this could be used to help me? It's a relationship. When you are seeking a healthcare provider, it's a mutual relationship. So you want to make sure that you ask some questions. And if you do have questions, I can help you generate some of them to pose to the people that you may want to collaborate with. And then there's things like the bionic straw and the breather that are relatively inexpensive in the scheme of things that can be very effective in helping managing certain symptoms. So I will say that most MS patients benefit from an evaluation once a year because then we have historical data. God forbid something happens along the way and you need paperwork or documentation for disability or anything else, God forbid. You can come back to me and say, hey, Dr. B, or hey, whomever, I need to show that there's been a significant change in my function. Well, guess what? You've done a yearly check-in with me. And I have 5 reports or 6 reports to provide you so you can advocate for your care. You can't do that if you don't have a check-in with us at one point in time. So, do you need the intervention of a medical speech pathologist who's an MSCS certified specialist? Well, consider asking yourself these questions every 6 months. Do you believe your speech can sometimes be sloppy, slurry, difficult to understand, or effortful? How about your vocal volume? Do you believe it's low, vocal fatigue, or strain or stress? Do you experience challenges, coughing when eating or drinking, the sensation of something caught in your throat clearing, or unintentional weight loss? These are simple ways for you to identify whether you need the immediate assistance of a medical speech pathologist or if it's something that you can continue to monitor yourself. So in short, treatment is most effective when you can be paired with somebody who is an MSCS rehabilitation professional. If they are not available in your immediate area, okay, then consider going to web-based interventions because your disease and disorder deserves to be treated by somebody who understands your disease and disorder and has certification in that, right? So that's important to know. So we are out there all across the country, but if they're not available now, more than ever, telehealth is at your fingertips. And Medicare is paying for it. So yay. So go out there and advocate for your healthcare. If you're experiencing changes, remember it's time for you to take control of these symptoms. You are in control of your healthcare and don't allow changes in communication and swallowing to take you out of your conversations, to change your social interactions because you have so much life to live and you deserve to be a part of that dialogue. Okay. So
we have time for questions.
Yes, I'm so excited for questions. Here's my contact information. Okay, you can also just Google me. You will find me all over the web. You can find me on Facebook. You can hear my email. You can find me an Ask a Question button on my website. The phone number's here. Anything at all. Okay, so let's go ahead and look at questions.
We have a question from Jenny.
Okay, Jenny. Hi, Dr. B. My doctor had me go and have my esophagus stretched for my swallowing problems. So, Jenny, I cannot give you individualized medical care because I don't know the whole history. Some people can develop a tightness of the esophagus, what we call an esophageal stenosis or narrowing of the esophagus or the food tube. That is an esophageal dysphagia, and some people may need to have their esophagus stretched, but that will only be effective if the challenges that you're experiencing are between the esophagus, in the esophagus. Okay, that's the tube that's traveling the food from the hypopharynx down into the tummy. So that could be a possibility. But I would also encourage you to double check that you don't have challenges in swallowing at the upper part of the system, from the mouth to the entrance point of the esophagus, because that is a far, far more common place for somebody to experience their dysphagia associated with MS. So that very well may have been the right treatment. And if it's helping you, then great, but also consider looking at the top part of that swallowing mechanism as well. Do you see many swallowing issues with facial trigeminal neuralgia? Absolutely, yes. So whenever there is a change in sensation or pain or challenges at all with the facial musculature, obviously trigeminal neuralgia, we're looking at a very particular part of the facial nerves, but fifth cranial nerve, third cranial nerve, our seventh cranial nerve, all of these nerves play important roles. And when someone is experiencing trigeminal neuralgia, it will impact their swallowing. If they're experiencing pain, the inability to open the jaw the same way that they would, challenges and discomforts while chewing and making a bolus, all of these things can impact swallowing efficiency and safety. So yes, that is not uncommon and definitely should be looked at as a healthcare professional. You should not have to suffer through that trigeminal neuralgia without having support of a medical SLP. Great questions. Love them. Yeah. I can identify with trouble getting started to swallow or forgetting how. Any tips on that? It doesn't happen all the time. Sure, Beth, that's a great question. So many persons experience difficulty with the initiation of swallow. So one of the things I would like for you to mention is sometimes waking up the oral cavity can be an effective way. Now, of course, I cannot give you specific medical advice because I'm not your speech pathologist. I haven't examined you personally. But in general, what you would like to do is you would like to increase maybe the temperature, making it cold, which gives sensory awareness. So you know where the bolus is, and you may have a better initiation of swallow when you have something cold in your mouth, kind of amplifies everything. If the bolus is sour, right, doing lemon ices and things that are sour in nature or citrusy in nature have been shown to help initiation and swallow. But ultimately, sometimes just good old therapy, thinking about like, I'm going to take one hard swallow right now and being conscious of it. Remember, swallowing is largely involuntary. If you can make yourself a little bit more in control, with a little bit more cognitive awareness for the swallow, you may have an improved initiation and swallow. And of course, all the therapeutic techniques we talked about can have a role in improving the initiation of swallow. So I would go cold, sour, not too big of a bolus, not too small, like a nice teaspoon bolus with the thought with, I'm going to make one hard swallow. And that may help drive an improved initiation of swallow. Okay, how would I begin treatment with you? Oh, Frank, you're so kind. My contact information is there, and you are welcome to reach out to me, and whether me or any of my clinical members will be happy to assist you if you qualify. Hi, Dr. B, thanks for having us. After individuals complete the 16 sessions of LSVT, does keep up needed to take place to maintain progress? That's a great question, Brittany. Thanks for joining us. So typically persons with LSVT stop therapy after those 16 intensive 1-hour sessions in the course of a month. And then we typically like to do a check-in at 2 months after discharge. Quick Skype, hi, how are you? What's going on? Give me some of your ahs. Have you seen a change in that ability to sustain ah? And then we'll continue to check in every 2 months. These are not paid sessions. These are 10, 15 minutes. Hi, hello, how are you? I miss you. I hope you're doing well type of treatment sessions. And just to keep an eye on things. Now, sometimes patients come back to us because they've had an MS exacerbation. And then sometimes it is necessary to start an official 16 sessions of bona fide LSVT all over again. Great questions.
I have a question here from Robert. I've been trying to get him on here. He has a question through Skype through Zoom rather than through the chat.
No problem.
Giving him just a moment here to unmute.
And if anyone feels more confident asking their question by unmuting themselves and typing, that's just fine, right? Sometimes fine motor skills can be a challenge. Robert, do you want to ask a question? Well,
Robert, you're on.
Yeah.
hi, Robert, talk to me.
I've always had trouble swallowing.
Okay.
So my speech and OT have suggested that I eat with my head down and I drink after every bite. So
Okay. You're asking a very heated, debated question, Robert. You win an award from probably the most controversial answer. I am going to this response is my sole personal and professional expertise. It will not be liked or agreed upon globally, but I'm entitled to my professional opinion. Unless you have had a test, an objective test, that shows that when you put your chin to your chest, this is called a chin tuck, although it shouldn't be called a chin tuck, but it is called a chin tuck. And it shows to you, and you've had a video fluoroscopic evaluation or something called a modified barium swallow study, unless those video tests show that that improves the safety of your swallowing, that could be causing more harm than not. That particular technique, like a straw, same category. Straws can help, straws can hinder. A chin tuck can help, a chin tuck can hinder. They're highly individualized, and you need to have objective testing to ensure that that is good for you. Because it's good for you may not be good for Brenda or Patricia or me, right? So that's very, very important.
Yeah, I've had some tests done, but I don't know if I've had that barium test done.
Specifically, and that's a great point, because many times people have had these barium swallow tests, which are very important in understanding your swallowing difficulties, but unless they're going to actually test out the techniques that they're going to give you while being able to look at it, then it's not going to actually show us the effectiveness of the techniques.
And I've had some video done at Mayo Clinic, but now I have a second part that I'm having that just now happened. I've always had my lesions in my spine, but I just recently have had trouble swallowing pills, and food gets stuck, and I have to spit them back out. And I just recently have had an MRI that has new lesions in the brain. So I was wondering if that was I'm having an esophagram scheduled.
Okay, so an esophagram, like our other friend mentioned, that is going to be an investigation of really just of the food tube itself, right? And it's not necessarily paying attention to the coordination necessary to successfully and safely manage pills, right? So I think an esophagram is great, but I think it's very important that you communicate with your healthcare provider that you may also want a true modified barium swallow study while swallowing pills or things that emulate pills. In my clinical practice, we use Tic Tacs covered in barium because they look like pills, but they're not pills, and to really better understand what's happening in the swallowing system.
That's what I was going to ask, what other tests I would need done, because at Mayo, they did have me swallow food, and they took pictures of it.
And that's great. You just want to make sure that you're doing from the mouth all the way down to the tummy. So we call that a modified barium swallow study with an esophageal follow-through, or an esophagram as a separate test.
Okay, see, that was my questions. I thought they were too much to ask.
No, never, never, never. I will stay on and answer all your questions until I am literally pulled off with a hook. Until you get the hook, Dr. B is here to help you.
Well, that was all that I had.
It's my pleasure, Robert. Please keep in touch if I can be of any further assistance.
Thank you. I have your information.
Wonderful. Other questions, concerns, comments, suggestions?
Let me let me come back to something you mentioned very early on.
Whom am I speaking with?
This is Chris, your host.
Okay, yes, Chris, of course, please.
If only 2% of people with MS are appropriately referred for treatment of speech, voice, and swallowing disorders, how can people with MS be better advocates and get more referrals for these kind of treatments? What strategies can they adopt?
Well, I hope my entire presentation served as the catalyst for that very discussion. I always come to these conversations with hopefully an overabundance of enthusiasm for my job and advocacy. Like, you are your best advocate. So yes, asking yourself those questions as I illustrated. Let me go back a few slides, one moment. It allows me to. So here, asking yourself these questions. If you think you have even the slightest difficulty with any one of these things on this slide, you should say to your healthcare provider, I really would like a referral to a medical speech pathologist. You have the right to have anything investigated that's of your concern. I'd rather you come to me and I have nothing serious to report to you and have that serve as documentation than you come to me after 2 bouts of upper respiratory infections that were likely caused due to aspiration, and now I have to undo potentially years worth of incoordinated poor swallowing. So you just need to tell people, everyone, you are in the driver's seat of your healthcare. You say, hey, Dr. So-and-so, I've been experiencing some changes, or I'm just interested in learning more about my speech and swallowing. I'm going to seek out the assistance of a medical speech pathologist. In most states, you do not even need a physician's referral, and others you do, so it will depend upon where you're located. But advocate and don't say no, don't take no. It's only going to help them better understand you as an individual with the more information they have about these 2 different subsystems. So advocate for yourself. Don't take no for an answer. And also just reach out to people. Reach out to professionals like myself and similar individuals to help you get started while official referrals are en route. I hope that's helpful.
We don't appear to have any more questions, so.
And that's okay.
So if you have missed any part of this teleconference, it'll be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference will be Thursday, July 9th at noon Eastern, 11 a.m. Central, 10 a.m. Mountain, and 9 a.m. Pacific. Our speaker will be Dr. Ben Thrower of the Shepherd Center in Atlanta. His topic will be, I Gotta Go, Bladder Issues in MS. Be sure to be with us for that. We'd like to extend our sincerest thanks to all of our attendees for your participation, and especially to our guest today, Marissa Barrera. Thank you so much for the time you spent to prepare and share this information with us.
Thank you, everyone. Thank you for spending your lunch with me. I hope you enjoyed this Lunch and Learn series. I take away with this, keep your heads up tall, advocate for your health. Don't be a stranger to me and my colleagues. And thank you so much for MSF for allowing me this opportunity to share my love and my passion for providing optimal care for speech and swallowing. So unless there's anything else, shoot me an email. Bye from New York. Thank you, everyone. Bye.